Alright, this video is for the classification in the McKenzie world of the spinal pathologies. This is a kind of a definition of terms video, specifically describing the clinical characteristics of spinal, what they're calling other. And this, you don't get to their other classification of systems without exhausting the first big three. The first big three being derangement, dysfunction, and postural syndromes. This information is coming from the handbook for McKenzie Part A, lumbar spine. This is from January 2017. This is not from their textbook. This is just from their handbook. So you do not get to the other pathologies, or you do not get to this pathology of spinal other without kind of running through the other big ones. So big characteristic is they do not display the symptomatic or mechanical response of derangement. They do not display the symptomatic or mechanical response of dysfunction or postural syndromes. There is no lasting favorable response to anything that you're going to do. They get inconsistent responses to most things. There are subgroups of other. That's kind of the definition of this video. We're going to go through those subgroups specifically for the McKenzie certification exam in the event that it does come up. It's possible that it's on the exam. It's possible that it's not. It's possible that you are watching this video for that information. The McKenzie evaluation, the initial management pathway, key categories. We have mechanical evaluation. You have these kind of three pieces here. You're looking at simple backache, mechanical therapy, greater than 90%. Nerve root pathology, mechanical therapy, less than 10%. This is the one that we're talking about here, serious spinal pathologies. Less than 2% of the people coming to see you will be falling in this category. So some of these subgroups may present with recognizable symptomatic and mechanical responses, or not. It's kind of confusing sometimes. So what are we talking about, other? There are some serious pathologies that we could be concerned with. McKenzie is very specific. They say this is not an exhaustive list, but some of these other categories of other, we would be obviously concerned with cancer. You'd be looking for some clinical findings, red flags, weight loss, history of cancer, greater than 55 years old, progressive. You'd be looking at Cauda Equina syndrome or some sort of cord compression. Again, we're dealing with some saddle paresthesia, or anesthesia is what they call it here, some bowel bladder dysfunction, urinary retention, motor weakness, clumsiness in legs, etc. Spinal fracture, again, probably not going to respond very favorably to mechanical loading. Again, that is going to be kind of a, usually, well, what I would call like a home run, a cupcake. It's going to be teed up for you. Trauma. Got to have a trauma for a spinal fracture, unless there's some sort of overuse of prolonged steroid use or something like that. Neck or younger pars fracture type thing. You can have a spinal related infection, fever, malaise, pain, hurts all the time, some sort of abscess, etc. Or there can be a vascular problem, big one, AAA, abdominal aortic aneurysm in the lower back, looking for signs and symptoms of that. Some sort of cervical artery dissection in the neck, signs and symptoms of that as well. There's a couple of other big classification subgroups, what they kind of call their subgroup system. You have chronic pain syndrome, inflammatory. Inflammatory is a big one because when you're kind of going through the McKenzie pre-test practice stuff, the inflammatory topics come up frequently and regularly from my experience. And if you don't know what they mean when they say inflammatory, you're going to miss that. So inflammatory, the definition, that inflammatory arthropathy, rheumatoid, some sort of seronegative arthritis, ankylosing spondylitis, and those are going to be constant pain, inflammatory constant pain, hand in hand, boom, morning stiffness, etc. There are the other subgroups, all right? You got mechanically inconclusive, that's a big one. You cannot get to mechanically inconclusive until you've done their mechanical exam. You also mechanically unresponsive, MUR, mechanically unresponsive radiculopathy, so symptoms that are radicular in nature but does not respond to your mechanical exam. I currently have a patient like this right now. So those are just persistent symptoms, right? So mechanically unresponsive versus mechanically inconclusive. Mechanically inconclusive is going to be unknown musculoskeletal pathology versus a radicular. The mechanically unresponsive radicular is going to be a radicular presentation. You're thinking nerve root pathology, but it doesn't matter what you do, flexion, extension, lateral shifting, flexion rotations. It doesn't matter mechanically what you do, loading them into end range doesn't really do anything. Varying degrees of neurological signs and symptoms, no centralization, that's MUR. So post-surgical, home run again. Trauma, post-surgical, kind of easy. Did you have surgery? Yes, I did. Well, that's why your back hurts. Terrible answer under most normal circumstances, but that's a classification subgroup. So a couple other big ones here. SI joint, pregnancy-related pelvic girdle pain. So SI joint is, the McKenzie really misses the boat on this, in my personal experience, on this subtopic. I don't know that many things that are great at treating it either, but you just do all the SI joint tests and rule that out. If you have positive SI joint tests that are pain-provoking, and this is where it hurts, foreign finger sign, all that stuff, or pregnancy-related as well, also no-brainer. Spinal stenosis is another subcategory or subgroup here. Symptomatic degenerative restriction of spinal canal or the foramina. Thinking older pain or older population, leg symptoms, relieved with flexion-based activities. That's a big one with. That's kind of a big one with the stenosis group, and when it comes to this is where I try and combine topics. When we have somebody who we might kind of look at as potentially fitting in the stenosis category, but also response to flexion-based mechanical loading, it can be kind of difficult to pick and choose which is which. So for the spinal stenosis category, the criteria are older population, history of leg symptoms relieved by flexion, activities exacerbated with extension. So that's a big one. But, could also be a derangement that's flexion biased. So kind of not there yet still. Long-standing loss of extension, still sounds like a derangement. In the cervical spine, they can have arm symptoms and stuff like this. So spinal stenosis and a derangement are very close to me in kind of the diagnostic workup. You can have a structurally compromised tissue, soft tissue, bony change, compromising the joint integrity. Thinking some sort of a scoliosis, some sort of osteoporosis, some sort of a greater than grade 2 spondy. Instability of the upper cervical spine. They mentioned RA in the text here. Rheumatoid arthritis, that is. That one's going to be, you're going to have your clinician hat on, and you're going to be going, clicking, clunking, pain with motion. You're thinking instability. Structurally compromised is what they call it here. Those are ones where you're going to want to rule those out with further imaging. They don't talk about that classification system here, but kind of taking the next step further, structurally compromised, rule that out. Trauma, recovering trauma, so recent trauma associated with onset of symptoms. Post-whiplash is a big one in our world. And so kind of following the textbook here, we have this like guideline, right? So top of the list, we have some sort of history of physical examination. You want to rule out the serious pathologies first. You want to go through your provisional classification, okay? If you've been following along, we're gonna hopefully find derangement or dysfunction. Those are a little easier to figure out. Postural syndrome is typically going to be glaringly obvious. So, and then you have the other, not consistent with the 3 McKenzie syndromes. So it's just kind of like the flow chart. So the provisional classification, which they're going to want from you with the McKenzie protocol, if you are following along in this video, you want to confirm that classification. They say confirm within 3 to 5 visits. Just confirming, right? You're not talking about full-on treatment. Sometimes it's quick, sometimes it's not. But again, last little bit here. Derangement is going to be variable. Dysfunction is consistent. Postural, static loading. Other, you're just going to be a little bit confused. Like, it's not getting better, it's not getting worse. It's kind of not following any pattern. Think spinal other.